Okay, we're going to continue. So then our second option that we have, if they don't want to do the VA method, then it would be the VV, which is veno-venous. And this, as you see, is probably the most common type of ECMO that there is. And you're not having to deal with two separate catheters. It's just one catheter that will be inserted, and it's going to be two channels in the catheter. One side of the catheter, one channel is going to be responsible for draining the blood, and then the other side would be reintroducing it back or reinfusing it. And this is going to create like what they call like a parallel circulation kind of thing going on. And that's comparing the drainage and reinfusion to the patient's normal circulation. And then when we look at the picture, I guess I'll try to explain that a little bit better. Now with the VV, all you're going to get is lung support. You're not going to get any cardiac support with VV because you're only taking blood out from the right side, and then you're reintroducing it back or reinfusing it right back to the right side, which means that the heart still has to be able to maintain the cardiac output. And because you are using one catheter and it's in one area, as the blood gets reintroduced back to the patient's system or reinfused back into the system, there is going to be some mixing going on. And that's when they really have to keep an eye on the saturation to kind of see what's going on. So then this is what a typical VV setup would look like. Again, you got one catheter and there's two different channels or lumens inside of the catheter, and the same insertion site, they're going to probably insert it in the right internal jugular vein. And then the whole parallel circulation business, as this catheter is draining and reintroducing blood, it's pretty much going to be it's going to be, again, it's going to be almost like the same rate, I guess you could say, as the blood is circulating through the heart. Now, if there's a problem, if they notice there's a huge difference between, say, like the mixed venous saturation and the SaO2, then that would lead them to believe that there's way too much mixing going on here, and then they're going to make some adjustments to the machine. So as far as the oxygenation, I mean, it's still better than nothing. I mean, you can expect sometimes the saturations to be maybe mid 80s, and if you have someone who's got really bad RDS, that's probably a much better improvement anyway compared to when they weren't on ECMO. And then the cardiac output. So changes in cardiac output is not going to have a significant effect on oxygenation. So what this is saying is that unlike the VA, where they can change the pump speed, and then that's essentially going to change the baby's cardiac output, with the VV, it doesn't work that way. I mean, they can still change the pump speed, but it's not necessarily going to change the patient's cardiac output. And because of the fact that the amount of blood that's being drained is pretty much the same as the blood that's being reinfused, then they're not going to be that concerned about hypotension and other kind of hemodynamic issues that could happen with the VA. And then we have some advantages here for sure over the VA system because you're only, again, using one catheter. So you don't have to worry about two different insertion sites. And then number two, the full native blood flow is going to be preserved, meaning that, again, this catheter is not going to affect the patient's cardiac output at all, no matter what they do with the settings on the machine. And then you only get one catheter, and that lessens your potential of having a source for an embolus. And then if we had to look at like the one big major disadvantage of this VV system is that if the heart is not doing that well, then VV is not going to help. You're going to have to consider VA. But if they have a pretty good heart and it's just that the lungs are bad, then VV is usually the way to go. Now, the actual parts of the system, and we're just going to look at it from pretty much like the surface level. We're not going to really get into every tiny detail because that's why you, the specialist, would have to get the training to really understand all of the ins and outs. But really, there aren't that many components to this ECMO system. We've got to have a pump, of course. And then there's going to be a lot of different, they call them monitoring modules, just meaning that there's going to have to be sensors and other things that are going to be keeping track of your pump speed, your pressures in the system, and also the patient's parameters. So you got all this stuff is going to have to be monitored. Your gas, rate of gas flow, et cetera, temperature, and et cetera, et cetera. The gas metering device, that would be like the like your standard like a flow meter type of system where you're going to be turning the flow higher or lower, and that would be for the O2 as well as like your gas, your sweep gas. And then the circuit, of course, is a specialized circuit for just this reason. And then you're going to have your membrane oxygenator. So the membrane oxygenator is definitely the lungs of this system, which is going to do all of the gas exchanging. And then the blood, after it's taken out of the body and it's processed this way, it has to be reheated back to body temperature before it's reinfused back into the patient. So you got to have some type of heater or water type of a system within that. So then when we look at the pumps in a little bit more detail, we know that the pump is essentially acting almost like a heart, and that it's going to ensure that the blood continues to move. And the way that these pumps work, you could have what's called the occlusive roller type pump, or it could be a centrifugal type of system. And your occlusive rollers, this is pretty standard with a lot of equipment that you'll see at the bedside, like IV pumps are usually working this way, where they're pinching they're pinching the tubing, and as this thing circulates or as it revolves, the rollers on the end are just squeezing. It's almost like milking, or I guess you can think of like squeezing the tube of toothpaste, and that's going to ensure that the blood moves forward. Now they have to be monitoring this pump and make sure that they're not over occluding, and they can make those adjustments as they need to, because if you're squeezing the tube too tightly, then you could cause some problems you can cause the blood to break down. So you can get like hemolysis of the actual blood. And we know that's not good. So the baby's blood is, of course, being taken out of the body and processed and then reinfused. But then, of course, sometimes they're having to give blood products as well. They're having to hang blood. And again, all of this has got to be monitored very carefully, and they have to make adjustments as they need to. And then there's a necessary balance between over occluding and under occluding. So if they don't have these adjusted and the rollers are just barely squeezing the tubing, then we know that's going to limit the amount of blood flow through the circuit. So then if it's not, again, not the occlusive roller type of pump, then it's going to be a pump that just spins and spins and spins and using centrifugal force to make the blood move. The membrane itself. Well, the membrane, the silicone that they use, there's layers essentially, and the blood is going to pass through one of those layers, and it's the thickness of the blood film that's going to make the difference between a membrane oxygenator that works very well and one that doesn't work that well. So it's almost like the thinner that you make that film of blood, the more surface area you're going to definitely have for gas diffusion to take place. And that's how you're going to get the best oxygenation and ventilation, really. So a lot of times, one membrane oxygenator may work a little bit better than another company's because the first company found a way to make that blood layer extremely, extremely thin, or those layers of blood between them very, very thin. For some weird reason, this just reminds me of how they make croissants, where they take these big blocks of butter and just kind of roll them out, and it's like one thin layer, and then they take another block of butter and then they fold it over, and they keep layering and keep layering. And so that way, when you do bake the croissant, you've got all these different layers, and they're very thin. So that's pretty much what the membrane oxygenator is. It's just a bunch of little silicone membranes that, well, good, yeah, I'm hungry. I think that's why my mind went straight to croissant. But you got all these little layers of these silicone membranes with the blood in between, and the thinner the layer of the blood, the better the gas exchange. Now, as far as the temperature, so some kind of heat pump or something, or some kind of water bath type of setup where that's all its job, that's the only thing its job is to ensure that there's the right temperature before the blood gets reinfused back into the body. And then this is convenient. They make these filters, they call hemofilters, that will help you take care of two issues at the same time. So if the baby has to get ECMO, then a lot of times they may have to have a little bit more help as far as like renal function. So this is essentially like it's the same type of hemofilter that you would see in a dialysis machine. And they would just add this on to the circuit wherever it would go. And then you get two things at the same time. You get the ECMO and you get some dialysis going really with this as well. Now, as far as the blood thinners that will have to be given, they'll have to be given continuously. So it's not just a give as needed or give on a schedule. It's going to be a continuous infusion of some type of heparin or something. These circuits that are designed for ECMO, there's nothing they can do to try to make the inner surface not coagulate. I mean, there's absolutely really nothing because of the material that's being used. As you see here, as soon as the blood comes into contact, it's going to try to clot. So that's why you got to have that heparin going continuously. Now, let's say that you've got a baby who, despite being given this continuous heparin therapy, there's still a lot of clots that keep happening in your circuit. And it's like creating a lot of problems. And you're just not going to be able to properly do your ECMO. Because they're constantly sending blood to the lab to check things like checking H&H and checking red blood, everything. They're checking everything essentially. This is one of those things they really would have to consider looking into deeper. If there's a lot of clotting, despite the heparin, then there may be what's called an antithrombin 3 deficiency. And if they don't have this cofactor here, then they're for sure the heparin is not going to prevent the blood from clotting. And as I said before, if you're the ECMO specialist, you've got to keep a really close eye on everything. And sometimes it may just be you by yourself, and other times it may be you and a partner. But either way, it's all about patient safety, as we know, when it comes to monitoring, and especially if you're doing something that's going to be this critical. So all those modules that were mentioned in the other slide, as far as the components of the ECMO system, there's got to be monitoring modules. We could just say that, all right, here's one. There's one that needs to be monitored, and there's another one. Got to monitor that, and that, and that, and that, and that. And there's your flow meters for your sweep speed and your O2. And here's our blender. That's our FiO2 blender right there. And so this is just the machine itself. And there's, of course, there's the pump. It's probably the occlusive pump that's going on. And there's something down here I can't really see, but just know that, and there's the filter. Now just know that in addition to all of this, the baby is on the monitor somewhere. I can't see, but the baby has EKG leads on, so I can't see where the actual ECG monitor is, but you got to monitor that as well. And then the baby's on the ventilator. So if you are the ECMO specialist, even if you're an RT, you're still not going to be expected to monitor the ventilator because you got enough going on as is. You got to focus on the ECMO machine and the patient's overall clinical situation and things like that. So that would mean that, let's say that this guy is the ECMO specialist, but he also is an RT. Well, there's going to be another RT that has to monitor and keep up with the ventilator. As you can see over here, here's the Draeger. There's the vent here. And this poor baby has a chest tube in place. So there's the chest tube hanging off to the side. So I guess all this is just to say that there's a lot going on, and it's a specialty, and you're going to get paid more for sure for having to be able to keep up with what's going on with this kind of a system. Now, as far as the circuit itself, you're watching it, of course, you're watching everything, all as the blood is circulating, and you're making sure that if there are any bubbles or clots, well, first of all, the machine should start alarming, or the system should start alarming to let you know that there's a there's a possible discrepancy maybe in pressures. So that's what's called a pre-membrane pressure and I guess post-membrane pressure. If there's any differences between that, then that would probably mean that there is some kind of bubble in the system or some kind of clot. And so when that alarm goes off, then you're supposed to immediately stop the ECMO machine and go into troubleshooting. But then you got to be quick about it because you don't want to, of course, for a baby who's really, really sick, you don't want to spend a lot of time pausing as you're trying to to figure this out. The way that these circuits are set up, I believe there's a way where even if you have to pause temporarily to troubleshoot for like a clot or a bubble, I think there's a way that you can temporarily bypass and still provide the support to the baby. I'm not 100% sure on that. I was just looking at some of the pictures and I've seen some of the circuits that look a little bit different than other circuits. So that could be one of the things that they built into the. But I do know they do have to temporarily stop the blood flow, whether they use the Kelly clamp, so the actual the hemostat, and then try to take care of the clot or the bubble. So lots of things again to keep an eye on, especially when it comes to alarms. And of course, the baby hemodynamically is going to have to be on the monitor, as we know. So you got to be watching all of that as well. And then as far as the blood tests, then they run a lot of tests on these patients. So not only are you concerned about clotting, you're going to be looking for platelet counts and hemoglobin, hematocrit, and then overall, how is the pH now, and how is the CO2, and et cetera. Now, again, because of this circuit is not really, they can't really design them to be first of all to prevent clots. That's one thing they can't do, and because of the fact that the blood will try to clot on the inside of the circuit, then they know that they have to they got to give the patient platelets. It's just got one of those things that's just going to happen. Now, as far as the hemoglobin hematocrit, this is just, of course, our formula that we use to figure out the total O2 content of the arterial blood, the CaO2. And of course, I wrote the arrow here to say that that's why they're really keeping a track on the hemoglobin, because we know that the majority of the O2 is transported this way. And if the baby's hemoglobin is not that great, then all of these efforts that you're making with your ECMO system is not really going to benefit the baby until you can get the hemoglobin back up, which will mean, of course, giving more blood. Neuro. So if the baby's now undergoing ECMO, then there's a lot going on as is, but then they also have to have other tests done. So as they say here, maybe they gotta get an ultrasound. So they'll just roll an ultrasound machine over, not the specialist, of course, but whoever's doing the ultrasound will have to do their assessment or their evaluation. And then because of this type of a system and this type of a procedure, the baby has to be completely paralyzed. They've got to be completely sedated. And because they have to be completely sedated and paralyzed, when they do their their physical exams. So like say the neonatologist is, making his or her rounds and they're rounding on this baby, then they already know that there's not much they can expect if the baby's completely paralyzed and sedated. So it just means that it's going to be kind of hard to predict what's going to happen as far as neuro with this baby who's getting ECMO if you can't assess the actual neurological responses like you would want to. But that's something you have to take into consideration, that we're just going to be, it's almost like you're going to be kind of blind for a little while as far as, well, you don't really know how the baby's going to end up like much later after this fact. And that, that's just one of the things that they have to take as is. And I mentioned also before that a small baby, those like really, really small babies are already probably experiencing some type of brain bleeding or and some type of intraventricular hemorrhaging or intracranial hemorrhaging. And being on continuous heparin therapy is only going to exacerbate that or potentially exacerbate that. So that's why, again, the really, really small babies usually don't qualify anyway. But let's say you have a baby who does qualify, and maybe this baby only has a grade 1 bleed. We just have to be very careful because all of that heparin could probably make that end up like a grade 2 or maybe even a grade 3. But again, they have to do like CTs and everything else to check to make sure that there is no bleeding or any extra bleeding or that, things have gotten worse. So all this is just to say that there's a lot of other testing that's going to need to be done on a routine basis just to make sure that everything is okay. Now, so respiratory support. Now, again, if the baby has, say, like really bad meconium aspiration syndrome, and that led to hypoxemic failure or PPHN, then we know that VV is going to be the way that they go. Now, the lung protective strategies, this is just the same as with the adults when we're really trying to be careful with our volumes and our pressures to make sure that we don't create more problems, because with newborns, the longer they stay on the ventilator, and if you're not being careful with your pressures, then they will a lot of times end up experiencing BPD. And as we know, that's going to be a chronic kind of issue for them from that point forward. So then here's some information they give us as far as if you've got a baby who's getting ECMO and you're concerned about minimizing the potential for lung injury, tidal volume 5 to 7. Of course, this would apply to an older patient, like a bigger child, a pediatric. 10 to 12 breaths per minute, and then the peak inspiratory pressure, PIP, no more than about 25 to 27 is good if you're going to be using a protective strategy. And then trying to keep the peak as low as possible as well. Now, fluid balance, and then just overall nutrition. Now, this is something that we know is going to be hard enough as is when you've got someone who's critically ill. It's really hard to keep them in what's considered a good state or good balance. But during ECMO, things are kind of like in flux. You've got, say like you've got a VA type of ECMO system going. You've got blood being drained out of the body, and then you've got the baby's natural circulation that's still pumping a little bit of blood, and then you've got blood being reintroduced back into the body. So that means that it's going to be very, very hard for them to keep everything in balance as far as fluids. So they're giving IV fluids continuously, and they got to regulate those rates of fluid infusion and try to do the best they can with this fluid balance. Now, let's say the baby is starting to retain too much fluid during ECMO, then the go-to is to give some kind of diuretic, like Lasix to diurese them. And also remember that hemofiltration filter, hemo filter can be something they would probably have to consider as well. And the last point here is saying if you waited a little bit too late before you start ECMO, then that could really complicate matters, because long-term hypoxemia is going to create a lot of issues as far as all your organs. And there's going to be some extra challenges for the ECMO team if you got a case like this. But in most situations, this won't be that much of a concern, because they'll be screening and they'll be considering these options as far as like ECMO much earlier than later. Now, when it's time to start weaning from the ECMO machine, they got two different ways that they could approach this, and they could just flat out just start weaning, or they could just do what's called a periodic testing. And weaning would be just turning down your pump speed, just, literally like just slowly, based on some strategy or whatever it is that they may be using to see how the baby responds. And as they're turning down the pump speed, they got to make sure that the therapist is increasing ventilatory support. So maybe turning up the settings on the ventilator, because it would be a disaster if you have a case where they're weaning down the pump speed on the ECMO, and the baby's not getting any extra help with the ventilator at all. Okay, and then they gave us a standard here. I guess it would be kind of considered a standard, but this would, of course, vary depending on the facilities. But if they can get down to a minimum support of like 20 to 30 milliliters per kg, then that would be probably considered, okay, we could probably discontinue ECMO. And then the periodic testing would be just looking at everything to see how are the chest x-rays now, and how are the lungs, how's the compliance and things like that. So then if everything starts to look fine, then that's when they may consider to just, okay, let's turn off the ECMO and see how the baby does, or see how the child does. Now, as far as the troubleshooting and all the complications, then we know that with something like this, you never know what could possibly happen. You just have to be prepared for the unexpected. So the unplanned decannulation. Now, the baby is supposed to be completely paralyzed and sedated. And a lot of times what they'll do in addition to that, and I've seen this happen not for ECMO, but just for other reasons where you didn't want this baby to do anything at all, they would tape them down to the bed. They would literally just take some tape and start to kind of like create like a little, what would you call that? Not necessarily tie them down to the bed, but tape them so that way if they do start try to move, then they don't move. A lot of times the neonatologists would tape them down as well when they're trying to do some kind of procedure where they really don't want them to move as well. But in those unlikely events, say like the cannula came out, I'm thinking this is probably, you're in a tight spot, you're in a tight situation, and maybe somebody walked by and they accidentally tripped over something, and you just have to be prepared. And then the circuit itself, or any of those little parts, you got to be on the lookout for issues with them as well. And then when you do see that big bubble in the circuit that's trying to make its way back to the patient, then you're definitely going to have to clamp off that tubing. They call it the racetrack. You're going to have to clamp off the area of the racetrack where you do see the actual bubble and take care of that, so that way you don't, of course, run the risk of the patient ending up with a problem. And as far as the physiologic, all of that anticoagulant therapy, it's not good for any patient, much less someone who already probably has a bleed to begin with in the brain. And then if you're the ECMO specialist, it's all about troubleshooting and monitoring and troubleshooting. So that's pretty much the bulk of your responsibilities, is just to be always on the lookout. As I said before, watching everything like a hawk to make sure that everything is okay, because this is serious. I mean, if something goes wrong, then you can imagine the outcome. And speaking of outcomes, of course, when it comes to any kind of therapy, we want to hopefully have our patients recover enough so that they will be okay. And as far as like, there's going to be no long-term complications or no extreme like disabilities and limitations that they would end up having. Now, the last thing right here, 65% of babies after ECMO, they did fine and they were discharged. And then some of them, of course, their complications were just, I mean, their issues were just too extensive to even begin with. And even with the ECMO, it just wasn't maybe enough. But these numbers, again, they get better all the time because we learn as we go, and then we make improvements on the equipment and our procedures themselves and training and all this stuff. And that's why you need all this information, so that way you can see what you need to do to improve. All right, then chapter 34 is transport. And what we'll do with this chapter is just kind of, again, take a surface level look at what it means when we say transport. And depending on where you work, sometimes they'll call this intra-hospital transport. And then other places will call it inter-hospital transport, meaning that maybe your facility is just not equipped to handle this sick baby. I mean, your nursery is probably only like a level 1 well baby nursery, or maybe a level 2, and you need this baby to get some ECMO, so you have to go to like a level 4. And then we'll talk about the options that you have for transport, and then what's the good and what's the not so good. Because with each one, there's always there's a pro and a con that we have to think about. And then equipment, that's important. So we got to be thinking about what we need to get the job done. Assessment is just assessment. If you're doing the transporting, you're assessing before, you're assessing during the transport, and you're going to assess after you reach your destination as well, before you complete your handoff. The very last part of the chapter is just, some more about the accreditation requirements that any transport team is going to need to be always conscious of and be aware of, so that way they're making sure that they're aligned with all of these standards. And there's a lot of accreditors that are going to be expecting your transport team to function a certain way, or operate a certain way, I should say. Now, who is on this transport team? Well, a lot of times there's a flight nurse, um, maybe there's an RT, maybe there's an EMT, maybe there's a neonatal nurse practitioner, maybe there's a physician. Not common that you're going to find a physician doing the transporting, but they'll always be in contact with the physician. They'll be always calling the physician for new orders or to give updates and things like that. Now, as far as if you want to be on transport, some hospitals, of course, do all their training in-house, and it's just a waiting list. A lot of times, I mean, everybody seems to want to be on the transport team, but they only have so many slots available. And the people who get on the transport team, say if it's like the hospital's transport team, they usually, that's like a cushion job for them, because not only are they going to be getting their base pay, but they're also going to be getting this extra pay as soon as they do get called for transport. So it's kind of cushy, I guess, when you look at it like that. Now, the topics of training, and we'll talk a little bit about that as far as, it's not that much extra training. I mean, of course, of all, you have to have your medical license. You've got to be a therapist, you got to be a nurse, and it goes from there. You got to maintain your NRP, you got to maintain your PALS, and your basic BLS. And they do a lot of you have to do some continuing education, and you have to be checked off, and you have to do training. So a lot of it is just sim based, like eSIMs or something along that lines, or maybe like using, as we'll see, a sim rig. Now here, I wanted to kind of just show you, if you're going to be on the transport team, maybe the hospital, say if this is all in-house, maybe the hospital would also expect you to pass this certification exam, which is the neonatal pediatric transport certification. If you already have your NRP and you've had some kind of, at least like some kind of introductory course to neonatal and pediatric care, a lot of those questions are not that hard. Let me see if I can find the website here. So here's the website. They give you some sample questions. So, well, first of all, let's just run through this. Again, if this is the hospital saying you have to have this, they'll pay for all this, though. Of course, you don't have to worry about coming out of pocket for that. And okay, here we go. So, take a look at this question here. Now, as a therapist, airway is always going to take priority for someone who's critically ill, always. AVOC is the acronym that we always use for that. So A is the answer here. And then the rest of this stuff, they will give you some study materials that you could study up on before you even took this exam, just to make sure, as far as the different topic areas, that you're going to be okay. And then I'm going to jump over here to this fourth question here. Things like this, like we know how important it is that we try to keep the newborns especially warm, because they can't really thermoregulate yet. They can't shiver to try to get their core body temperatures up. And then so forth and so forth. But again, it's not that bad when you think about it. Now, Now, I included this picture right here because if you are going to be doing, say, like a transport, say you're, you and an RN. Now, what if something, God forbid, what if something happens to the pilot in the middle of the flight? That means that you and the nurse are both going to need to have some kind of understanding of what these controls are and how to safely land this plane once you get in contact with the tower and they start to guide you. So they say, okay, change your heading to blah, 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 blah. You're going to have to find the button on that panel that will allow you to change your heading. And they say, okay, decrease your altitude by blah, blah, blah. So in other words, all this extra training that you have to get, it's all necessary because we always have to just prepare and plan for the emergencies and the unexpected. Now, the different options that we have for transport. When we start looking at any program, so whether it's the hospital that's maintaining their own transport, the first place I worked right out of school, it was all in-house. It was the hospital, and we had a helicopter, and we had like a helipad. No, I take that back. We only had, wait, was that our helicopter? It was. Now I think about it. When I first started out, I wasn't in the nursery. I was in the adult ICU. But anytime that one of the nursery therapists ended up having to do a transport, they would have to call one of us from one of the other areas to temporarily go and pick up that therapist's workload while they were out doing transport. And then after they got back, then we just would go back to our area where we were. So your equipment is going to be the most costly. Again, whether it's in hospital or outside, external. And you think about it, you got a fleet of vehicles, maybe, and they're going to all need some maintenance. And they're going to need preventive maintenance. And then they have to have certain components, of course, like 1 through 5. No matter what type of transport vehicle, whether it's ground transport or air transport, you got to have some means of being able to plug in your medical devices. You got to have some kind of like AC power outlet kind of thing going on. And also you're going to need to have the ability to transport your gas cylinders. And you got to have suction, of course. You're going to have to suction as needed. And then the inside, it's got to be big enough a lot of times just to house or seat 2 people at least. And then of course the radio, got to have some kind of communication. So now we'll talk about ground transport. So this is going to probably be like, one of the more common things that you'd expect to happen. You're going to have to call the transport company, and they're going to send over, a vehicle, an ambulance, or whatever the case may be. And if you got someone who needs to be transported just down the street to the next hospital, and it's not more than 30 miles, then this is the most cost efficient way. Or maybe if they're not that sick and the hospital is, less than 80 miles, then again, this is still going to be most cost efficient. And your rig has to have the means of being able to lift the patient up. So it's got to have some kind of hydraulic system, as we know. And again, as far as how many people can fit, at least a couple of people, you should be able to have that room. And then what if you got to transport twins? So then you got to have room that you stack or align the incubators, back to back with each other. So this is a nice little setup. I'm thinking maybe this is just a simulator. I don't think this is a real actual ambulance, but you got plenty of seating. You got seating here, you got seating there. You got, of course, seat there. And I can't see much else, but this looks to be luxurious when you think about it, as far as like what you really have available and some standard vehicles. And it's hard to see, but there's your panel. There's, of course, where you're going to connect your ventilator if you need to. There's the suction canister here, and I can't see much else that's going on. So then we look at the pros and cons of doing ground transport. So of course, this is going to be your cheapest method when you think about it. As long as it fits that criteria. If you got a baby who's really, really sick, as long as you're not having to go more than 30 miles, or if they're not that sick, as long as you're not having to go more than 80 miles to your destination, then this is going to be the most cost effective. And again, as we saw the previous picture, that was a real transport vehicle. Yeah, plenty of space. And if it's raining, not a problem. But the disadvantages, we know that in bigger cities, I mean, with traffic, sometimes there is no rush hour traffic. It's just always traffic on the freeways in most cities, as we know, most like metropolitan areas. So then that means that there's going to be that kind of a challenge. And then the third point is these are not Cadillacs and Mercedes. I mean, they're not designed with like the most comfortable air suspension and that sort of thing. So there's going to be a lot of jostling around and bumping around. So then that could be something that you'd have to take into consideration as far as, it's going to be a probably bumpy ride, especially if the streets are not that great to begin with. Now, rotary wing. This is, of course, just your helicopter. And helicopters, of course, are going to be your best bet if you have to go a little bit farther, like your hospital is maybe a little bit over 100 miles away. Then you're going to save a lot of time by just getting in your helicopter and taking that option. And unfortunately, notice how cramped it is inside of the fuselage of a helicopter. It's just not going to be roomy no matter what. Even the military type transport helicopters, and they're definitely much bigger than a standard helicopter, but still, what's dictating how big these devices or how big these machines can be is their ability to lift, as far as like the weight, the payload. So if you ever did like one of those, I think Vegas does a lot of these, like where you can do some sightseeing over the city and they'll take you up in a helicopter and then they'll start, of course, pointing out, if you notice there's the blah, blah, blah. Sometimes I think they fly to Hoover Dam and, that sort of thing. If you sign up to do one of those, they're going to ask you how much you weigh. So that way they can figure out exactly how many people they can safely fit at one time without any problems. So when you think about your transport team, you got your 2 members, then you got the pilot, and then you've got the equipment itself. You got the incubator, then you're possibly bringing on some tanks, and all that stuff has to be factored out. Somebody has to do the math and kind of estimate and figure out how much is going to be too much. So unfortunately, you usually end up with a very, very tiny space. As far as the advantages and disadvantages, as we know, compared to, say, ground transport, this is going to be much faster. And if you have a hospital that has a helipad, or or not even a dedicated helipad, as long as there's a little bit of area, a cleared area where they can land in the parking lot, as long as there's no cars around. So then that's pretty convenient. Now, as far as disadvantages, as we know, fuel is not going to be cheap for a helicopter. I mean, when you compare it to, say, like just gas and a ground transport vehicle. And then you can imagine what the maintenance bills are like for a helicopter. There was a physician in LA. He was a Kaiser physician. Everybody knew him because he owned his own helicopter, and he didn't have to worry about traffic when he had to go and see his patients, when he had to go from one hospital to another hospital. He would just jump in his helicopter and take care of things like that. But I can only imagine how much that would cost to maintain. And then if you do have to fly further, again, you can get up, I mean, they say like up to 150-mile radius. You might have to stop and get gas, but that's usually not that likely. And again, it's all about weight and how much fuel that they could probably hold at one time, depending on how much extra equipment they're going to have to transport. So they may not be able to hold as much fuel, or they may not be able to fill up completely full. And in which case, they may have to stop and get some more gas somewhere. But I don't believe so. I don't ever remember that being a concern at the hospital that I was working at, because, say, like one of the therapists would go out and then they come back and they never mention anything about, oh wow, we had to stop and get gas. They never mention anything like that. And then the cabin itself, so definitely, again, not much space to stretch out at all. And the no pressurization would mean that, well, as we get into the next form of transport, we'll talk about the advantages of having a cabin that you can literally pressurize versus one that you can't pressurize. So that just means that whatever the barometric pressure is at whatever altitude that you're flying in the helicopter, that's what your body is experiencing also at the same time. And as we know, the higher you go in altitude, the lower the barometric pressure, which means that oxygenation is going to be a concern if you're at a higher altitude. So then, of course, you're limited on how much you can take with you, because of, again, the machine can't lift off if it's too heavy. And then if you've got, say, a little bit of rain is not usually going to be a problem. If you got a pretty bad rainstorm, then they're not going to be able to use this. They can't just fly over the storm, because the helicopters are limited as far as, again, how high you can go. It's not that they can't go that high. It's just that you can't pressurize the cabin, which means you don't want to fly really, really high in a helicopter and be at an atmosphere where the barometric pressure is so low that you end up having some severe hypoxemia kind of situation going on. Now, the fixed wing. Now, this is, of course, like your standard, like your private jet, or just like a 2-engine type of plane or whatever. Sometimes it maybe looks like a little crop duster that they may be using, but it doesn't matter. They all consider to be fixed wing, unlike a rotary wing, which would be the helicopter. And if you've got to go, say, from East Coast to West Coast, or you got to go from LA to the Bahamas, you're going to have to use some type of jet or something, or some kind of fixed wing. Now, the main benefit of using a fixed wing type of craft is you're going to be able to pressurize the cabin. And if you pressurize the cabin, then the higher that you go, you're not going to be exposed to that same outside barometric pressure, because the inside cabin pressure is going to be higher. So when you got someone who's really, really sick, you're going to have to make sure that your cabin is pressurized before you even take off. And they'll take care of that before they start to even hit the runway. Now, this picture here's of course baby in the incubator, and the transport person here is doing an assessment in midair. Here's our galvanic fuel cell O2 analyzer. So even in mid-flight, you're still monitoring how much FiO2 that you're delivering inside of this isolette to the baby. And then here's apparently, I'm just going to say this is dad, and there's somebody up there. So this looks to be a really nice little, like one of those little Lear jets maybe. And maybe this is one of those where you're transporting the baby from this country to maybe another country to see some specialists, or from another country back to this country for whatever reason, or whatever the case may be. And then we get into the advantages here, and we know that if you got to go far, then you're limited as far as ground transport and rotary. And you can have a nice cabin area. So that previous picture, it wasn't the biggest, but as you know, when it comes to like these private jets, these Lear jets, they are not meant to be the same size as like a commercial jet, like a big jumbo jet. They're meant to be a little bit smaller, but still, compared to say like a helicopter, you're going to have more room inside of one of these devices. And again, you're going to be able to pressurize the cabin before you even take off, so that way, when you're at your cruising altitude of however many feet, like maybe your cruising altitude of maybe 20,000 feet or 30,000 feet, whatever the barometric pressure is outside at that altitude is not going to be the same on the inside of the cabin. And let's say that there's a bad rainstorm, there's a bad thunderstorm that's going on. They can just literally fly above it. I mean, this happens all the time, like when you're doing a commercial jet, when you're on a commercial flight. Sometimes a pilot will tell you that, folks, we've been told that there's a storm, blah, blah, blah. We're just going to fly above it and climb even higher. Now, disadvantages. These jets are not cheap. Even the ones that are used, like say if you went online, maybe you went to Craigslist, because they sell everything on Craigslist. Maybe someone was selling their private jet, and it was a 2001 model. That thing is still going to be somewhere close to like maybe $1 million. So it could be pretty expensive if you're going to have a transport company and they've got a couple of these, and maybe some helicopters and the actual ground transport. So when you just think about it in general, this is going to be the most costly to maintain. And you've got to have an airport. So that's an inconvenience. Say you go from your hospital here, and then you're going to your receiving site. Your airport or your landing strip may be miles away from that receiving hospital, which means that once you get to that destination, now you got to wait for the ground transport to finish your to finish your mission. So then that could delay things as well. Oh, and before we get into the equipment, I worked with a therapist who did transport, and he was telling me about, he was at Oakland's Children, and he was on a transport from Oakland to somewhere, Jamaica or somewhere, and right before they got to their destination, the baby ended up having a pneumothorax right there in the ear. So with him, I think it was him and a nurse, you both have to be prepared for those kind of emergencies. So that meant that, of course, he had to do a needle decomp. He said it was the first time he had to do a needle decomp, and he hadn't been transporting for that long. And they got the baby stabilized, and then once they landed, of course, the baby got admitted, and they quickly had to insert a chest tube. But everything worked out because, he acted fast, and he recognized that the baby was experiencing a tension pneumo right there in the middle of that transport, or at least toward the end of that transport. Now, the equipment, you got to, of course, have your standard bedside type of equipment. And it looks like, well, let's just take a break because I still don't see Mrs. Goodman yet. So let's just take our.
Dr. Roper, I am here.
Oh, here you are.
I'll call you back.
Okay, all right. So this is a good time then.
Beautiful. I've been sitting in and reminiscing about my transport days. I was a transport therapist for many years and hated helicopters, only liked airplanes, but was a pro at being in the back of an ambulance. So great job, Dr. Roper. Okay, good morning, everyone. How are you? How's it going? Nobody talks? Okay. I've asked for some class time today to deliver a couple of news-worthy things to you. First off, I wanted to let everyone know that our esteemed Dr. Roper will be leaving us at the end of the semester, and he got may I share, Dr. Roper? Would you like to
sure. Oh, sure.
Would you like to share? Share, Dr. Roper.
Okay, so yeah, so this was like one of those hard decisions that I had to make, but I feel like that it was time to focus on another aspect of healthcare. And so there's a wellness clinic in Chicago who was looking for a research director. And so I applied last year, and then a few weeks ago, I started to get some communication from them, and they were very interested in having me come and start to kind of like, they've already been doing some studies, and they want me to kind of come in and help to increase that. And it looks like I'm getting more information. Thank you. I'm getting more information. They're now trying to do some more COVID type of research, and they're also looking into behavioral health and HIV, and also just overall like the disparity between certain racial groups and healthcare and that sort of thing. So yeah, thank you. I'm just, excited to now really use my graduate degrees. And again, it's still healthcare. It's just not, in this capacity anymore. So yeah, I told them that when he did ask if I was interested, I told him that I would have to at least finish off what I'm doing now, which is, of course, luckily it worked out where at the end of term 5, we're done with term 5. And then this company is saying, sure, you can start in the first week of May. So I've got to do a whirlwind relocation and get things going, and then just jump in and see what the future holds, as they say.
I couldn't be happier or prouder that someone from our faculty is leaving, going into healthcare. And Dr. Roper, you're gonna just rise so high. So congratulations.
Thank you.
On it, but very sad for us. For you as a class, know that we're leaving you in good hands as you move into semester 6. You will be working with Professor McCarl and Mr. Eden, who will be running. Mr. Eden will be running RC 290. Professor McCarl will be and is coming to talk to you on Wednesday about RC 280 and what he needs from you as you move into your last semester. How did that happen? I do have a little bit of news about myself as well. I am stepping down as director and will be leaving Carrington. It was a bittersweet, very difficult decision, but the time has chosen me. I haven't chosen the time. My family needs are taking precedence in this. Again, I leave you with great hands of Professor McCarl, Mr. Eden, and they will take great care of you. Nothing else should change for you. What I do want to say is in the future, as you graduate, you take your exams, get registered. I want you to do your best always. Practice with confidence, empathy, and heart, and you will go far in the RC world. I'm going to stay on. Does anyone have any questions for me or Dr. Roper?
I have a question.
Go ahead.
I know that you guys are both leaving. Congratulations. But do you have any news about what we're doing after this term with clinicals or anything?
Professor McCarl will come in on Wednesday and talk. So Elisa Marie, he's going to set the stage, tell you what's going on, tell you what our plan is. But we have worked out plans for everyone. Just so you guys know, I have all but 3 people that are graduating in the semester in front of you. Those other 3 people will be graduating probably within a couple of months.
Okay, so
go ahead.
Is our graduation date still the same, or has it been pushed back?
It has not been pushed back. We are going to try everything humanly possible not to push it back. Once we get one more place open, it's going to be way easier. So we have, we've run sim labs, we've done case studies, and mark my words, you will not be graduating without touching real patients. So you will have clinical experience. And then what I would, and Director or Professor McCarl is going to talk to you about this, but if you currently work in a hospital and you advocate for yourself to be able to go there, work with Professor McCarl. We've done that very successfully with 2, 3, or 4 of the people in the semester above you. So Elisa Marie, I know you work at Highland. Go to Highland and see if they'll take you.
I got Mr. DP the contract there.
Yes, you did. So use it to your advantage, my friend.
Okay.
Use it to your advantage. Pardon me?
Congratulations, you two.
Well, thank you.
Thank
Thank
you.
you. Any other questions? You guys know how to get a hold of me. If you need anything, I am here for you for a little while longer. Thank you. Thank you, Dr. Roper, for letting me interrupt.
You're welcome. You're welcome.
Okay. Congratulations. We'll talk soon.
Okay. Thank
Okay.
you.
Thank you, everyone. Bye-bye.
Okay. All but three of our. I think she was saying that for this current term 6, everybody has been out in clinical except for 3. Is that what she was saying? Yeah. So for sure on Wednesday when McCarl joins our meeting, he's going to let you know where he is as far as the placements and things like that. So yeah, whatever's going on with term 6 right now, it's not going to be the same for you guys. So in other words, they're anticipating everybody being placed. For you guys, all but 3. Okay, well, I'm gonna leave it up to him to give you the most current update that he has for these sites. And I don't know exactly how many. I can't remember how many people are in the term 6 group, but I'm thinking that you guys are a little bit fewer, maybe by a couple of people. So I'm thinking that should have an impact as well as far as how many positions, how many slots at whatever particular hospital. But again, that's his project that he's been working on, and he'll be the person to give us the most current updates on Wednesday. Yeah, so yeah, she says she'll be around. So she is, what is this? I think this is her last week. Yeah, this Friday is her last day. So yeah, be sure if you have anything specific that you need from her or want to ask of her, just do it before, I guess, end of day Friday. All right, now, well, let's do this. Let's just take a 10-minute break, and then when we come back from the 10-minute break, we'll definitely be finishing up this information here. So that way, I anticipate us being done before noon. We should be done well before noon, and then you have the rest of the day to work on your assignment or study.
Dr. Roper?
Yes.
As far as the next class, 279, will you be finishing that with us or no?
Yes, that's what I was saying. That was my condition with the new company.
Perfect.
I told them that I'm in the middle of teaching and that you guys aren't finished until the 22nd. So perfect. That's when they said it's fine, you could start the first week of May. Oh yeah, I'm not going to just walk out in the middle. I mean, that's just not right to, especially with us not having that many faculty to begin with, that would have created just too much unnecessary, how are we going to figure this out? How are we going to cover and that sort of thing? So yeah, student first. Just like we say patient first when you're in the hospital, patient first, and then you guys are student first. Okay, so yeah, let's take our 10-minute break, and we'll be back at 11:30 and finish the rest of the slides here. All right, so we are almost done with this chapter. So we're going to look at now some of the equipment that's expected for a transport, any basic transport. You're going to need, again, the same things that you would have at the bedside. And that would be, of course, the heart monitor, the ECG, the pulse ox, and blood pressure, and et cetera. Now, the ventilator, if it's going to be one of those kind of transport where the baby or the child is still going to be ventilated, then you would want your machine to be pretty similar to the one at the bedside, except it's got to be on a much smaller scale. It's got to be more lightweight, but it should still have the technology so that way it can do some of the same modes and provide some of the other same features. Now, volume control versus pressure control. Then a lot of these machines will have the ability to do both, and it'll just depend on the patient's needs. As far as if it's a newborn, then they are mostly ventilated in pressure control modes. And then if it's a larger child, then tidal volume is going to be set for some kind of volume control mode. Now, this would be extremely handy to have. They call these what is the nickname they give these things? I'm just going to call it portable ABG analyzer. A point of care. That's what I'm trying to say here. Now, with this, it's like checking your blood sugar. Like if you were, say, someone that had to keep track of your glucose level, and you just do like a finger stick, and then you use your little analyzer to see what your numbers are. This is kind of the same thing, except it's more comprehensive, and it's going to give you literally a blood gas report. And it's going to be able to, depending on the cartridge that you have, and this is the cartridge. Now, if you have a cartridge that can do more than just blood gases, and it can also give you potassium and sodium and et cetera, then it's still, you just apply your blood and then insert it into the device, and it'll give you that result right there on the spot. These point of care devices are extremely helpful even at the bedside. If you have a place that has invested in this kind of equipment and each therapist has his or her own device, then it makes things so much easier as far as taking care of the patient and making changes as you need to, and then just having that information right there in your hand instead of waiting for the lab to give you your results or for you having to go to the lab. Now, you're going to have some gas. Again, these devices, I mean, these transport vehicles are not going to have usually their own built-in system, so you may have to take some along with you. But that all depends as well on your vehicle that you're having. But in most cases, you're going to be thinking, I'm going to need to figure out how many tanks are going to be necessary. And this may not be your responsibility. It may be maybe the pilot's responsibility to tell you the limit as far as how many tanks and how much weight or whatever the case may be. Now, you're going to need to give sometimes maybe not 100%, but you're going to possibly have to maybe give them, say, like 30% oxygen or 40% oxygen, So you're going to need to have air in O2. And whatever your calculations come out to be, say that you do your duration of flow calculation for that particular size tank that you're using, and it says based on this tank and you're using it at this flow, the tank will last X amount of minutes or whatever the case is. And then you're going to have to now say, that means that I got to take 4 tanks. But just to be safe, it's always a good idea to double that amount, because you never know what could happen in the middle of your transport. So say you're on a ground transport and then the vehicle breaks down. So at least with your extra tanks that you brought as a safety, you've got something that can continue to support the patient. Your ventilators will use a lot of gas if you're connecting them directly to these tanks. And so at least if you've got a situation where you're having to wait for another vehicle, for someone to meet you and pick you up and take you on the rest of the way, you've got your backup. And also, as we've been saying, the weight of your payload, if you're going to be doing a fixed wing or a transport, they got to take that in consideration. Now, I wrote here, which one of these do you think is the heaviest? Now, this one here, this is a standard air compressor that you would have to plug into the AC outlet, and it'll just generate its own compressed air, versus here's just a tank of air. Now, I don't think we could really answer this question, because this looks like it's going to be pretty heavy, but sometimes they're not that heavy, and they may not be much heavier than the actual tanks themselves. But in other cases, they are going to be way too heavy, and you wouldn't even want to consider bringing something like this on your helicopter ride or the plane, because it's just going to be way too much extra weight. Patient assessment. So as we know, it's all about assessing, and you've got to work on your assessment skills always. And how this usually happens when you've got, say, a case where the baby would need to be transported to another facility, then the first thing is, you have to communicate with the place that you're trying to transport the child to. And then these are the standard things. Of course, it's kind of like your handoff report, more or less, or your S-bar. If you want to look at it that way, you're just having to let them know exactly what's going on, and especially anything that's going to be relevant. You've got to include that in your report. Okay, and now, how do they, once they do establish everything and they're going to make this happen, they're going to transfer from one facility to the next facility, then of course they have to be open to suggestions. So in other words, the hospital that's going to be receiving your patient, they may have their own recommendations to say, before you guys come over, why don't you make sure that the patient is getting another dose of blah, 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 or if you start antibiotic or whatever the case is, and then, they kind of go from there. And ordinarily, you really don't want to transport really, really, really sick patients, like really, really critically ill, but you may not have that option. Maybe have a case where this baby has to go now to the next facility. And then there's something that was mentioned here as far as if you're the transport team, what do you decide to do? Do you decide to take this really critically ill patient and just quickly try to get them transported to the next facility? Or do you try to get the patient as stable as possible before you place them on the vehicle? So scoop and run and stay and play. I mean, that's really what it comes down to. But ideally, your transports are probably going to be a little bit more smoother if your patient isn't that sick. I mean, meaning like they're that critical. Now, before we continue on, think about what happens like when you have, say, an unexpected situation where a baby was born at a facility that doesn't have the ability or the means to really take care of any baby except for very healthy babies. Then this kind of like a scoop and run and stay and play kind of relates to that as well, because before the baby was born, maybe the first hospital had a decision to make. Maybe they had to decide, do we have mom transported to the other place, which we know is going to be able to take care of any of the baby's needs? Or do we just go ahead and get the baby delivered here and then transport the baby up to the other facility? So either way, it's going to have to be a judgment call. Someone's got to make a judgment call, and usually, of course, the physician is going to be making that call. Now, altitude, as we know, Boyle's law says that pressure and volume are inversely related to each other. Now, if you start to climb, as far as altitude, you start ascending, you go to a higher altitude, we know that the barometric pressure drops. As you higher you go, the less barometric pressure that you're going to be experiencing up there. And the less pressure would mean that the volumes are going to expand. So now, before we get into what to expect, now let's think about what's going on with, say, you've got a child who's being transported, who's intubated, and this child's ET tube has a cuff. So we're talking about a bigger child, not a neonate. So this child's ET tube has a cuff, and because of Boyle's law, it's saying that as the pressure starts to decrease, the volume will start to increase. So now we're looking at the volume inside of that cuff. And now that you're at a higher altitude, you may have to go in and take out some of the air in the cuff temporarily. Because if you didn't, the whole time that you're up there during your transport, now that cuff is considered to be overinflated. And we're going to be always concerned about the tracheal problems that could happen with an overinflated cuff. But then the minute that you start to land, Boyle's law takes over again. So now that you're back at normal sea level, wherever you started off at, the pressures are now higher. And then the volume inside of that cuff is going to get smaller. So now the child is going to have a leak. It's going to have a major leak as soon as the plane starts to descend or starts to land. And there you have it. You got to now readjust the volume inside of the cuff again. You got to now add more air back to the cuff. So again, this is Boyle's law that you've got to take consideration. Same would go for your IV fluids. So as the IV fluids are being delivered to the patient, the IV tubing is pretty stiff, so it's pretty non-compliant, but it still is going to be affected by the changes in pressure. So that means that the IV fluid rates and things like that are going to have to be adjusted as needed as well. Now, so things that we definitely do expect to see, this is just your peripheral chemoreceptors that are responding to a higher altitude. And we know that that's the first thing that will happen as your PO2 starts to drop below 60, as we identified before. Once your PO2 starts to drop, your peripheral chemoreceptors will be activated, and then you start to become tachypnic. And I already mentioned about like the IV fluids because of the tubing. Nausea and vomiting is something that will happen. And this is not necessarily focusing on the patient, but this is like anybody in that craft. Anybody is likely going to experience these type of issues. Like they're going to feel nauseated, feel like they got to vomit, feel like you got to pee more. Again, that's the changes in pressure, how that's affecting you. And you may even feel a little bit more pain in some cases. And then 4, I already talked about the ET tube situation. You're going to have to take out some of that air once you're up in the once you're up in the air, and then once you start to land again, you're going to have to add the air back. Sinus pressure, we know that's always a pain to have if you're experienced or you're sensitive to those changes in pressure. Now, this last point here, if they pressurize the cabin before they take off, a lot of this is not going to be an issue. This is only going to, these issues right here, 1 through 5, are mostly associated with cabins that cannot be pressurized. So like the helicopter, for instance, or if you have, say, like a fixed wing transport system or plane, and it doesn't have the ability to pressurize the cabin. So I'm thinking like, think again like those little twin motor or twin propeller or even single propeller type planes. They can't pressurize the cabin. How does a jet pressurize its cabin? It's using its engines. It's pretty much, there's a video that I included with this week's information where you could take a look and see. They kind of talk about what's going on with that. But just to kind of generalize it, as the engines are revving up on the jet, the exhaust from those engines is being used, it's being redirected. Some of it is being redirected, so that way it pressurizes the inside of the cabin. As long as the doors are all closed and it's airtight inside, then this exhaust helps to increase this pressure inside the cabin. Now, because I knew this is what they do, the first time that I experienced sitting on a tarmac, I guess. I mean, sitting not on the tarmac, but just sitting at the gate. I don't remember which flight it was, but as they were, getting everything ready, and the engine started revving up, then the air coming out of the vents was so strong, as far as like jet fuel, it was to the point where you were almost gagging. But I knew what was going on. It was like, this is how they're pressurizing the cabin. And eventually, it died down a little bit where it wasn't as strong anymore. But, that's the thing. Anybody who didn't really understand this, they would probably think that there's something wrong with the plane. Like, why is all this jet fuel coming into, all this exhaust coming into the cabin itself? Now, the higher fuel consumption. So when they pressurize the cabin, they say to sea level. Well, really it's not exactly sea level. So in other words, they are not going to try to exactly mimic the exact 760 millimeters of mercury on the inside of the cabin as you would experience on the outside while you're just sitting on the ground. But they're going to pressurize it enough so that when you're up, say, like 20,000 feet or 30,000 feet, the inside pressure is still going to be higher than what's on the outside. So the thing about the fuel cost, if you try to pressurize your cabin to 760, you're limited on how high you're going to be able to go up into the atmosphere. And that's because of the changes in pressure. So the higher you go, the pressure on the outside is getting lesser and lesser. If the inside cabin pressure is 760, you go too high and the entire cabin will rupture. I mean, it'll literally just explode because of those extreme changes in pressure. 760 on the inside and maybe 400 or 300 on the outside. So as we know, pressure goes from high to low. It's going to be pushing and pushing and pushing on the cabin until it, again, it's going to try to equilibrate. So that means that they're going to have to drive. They're going to have to fly at a lower level if they've got their cabin pressurized to like sea level. And the lower that you're flying, the more drag or more resistance that there's going to be. More resistance to the jet means that the engines have to work harder. So now just think about when we talk about work or breathing. You've got increased resistance in the airways. Your diaphragm and everything else has got to work harder to get the air to go into your airways. It's kind of the same with the jet. If it's flying at a much lower altitude than it would normally fly, it's experiencing a whole lot more resistance because of the drag, and it burns more fuel. So now if they want to save money on gas, they have to fly higher, because the higher that you fly, the less resistance that there is up there, the less drag. And that's how they save a lot of money. So that means that you got to pressurize the cabin, true enough, but you can't pressurize it that much, because the more that you pressurize your cabin, the lower you got to fly so that the thing doesn't just essentially explode by, the extreme differences in pressure. So nitric oxide, NiNO, is something that if it was started at the bedside, you may want to continue even during transport. So they have devices that are specially designed to be portable, and they will just connect, as you see, like to the isolate on the outside. And you have to, of course, take along the nitric oxide tank as well. So that's another tank that you got to factor in as far as the weight, if it's like a helicopter or a rotary wing or a fixed wing. But the device itself is not that heavy. It's just, again, a little device that'll attach to the side of the bed somewhere. And a lot of times, most of our equipment is going to be battery operated. I mean, it'll have the ability to be powered by AC or battery, and your transport vehicle will have AC outlets. But even still, our equipment has to have the ability to just run strictly off of batteries. That's the most ideal type of transport equipment. And then not interfere with aircraft navigation. So the radio frequencies that these devices will sometimes be generating will a lot of times interfere with the radio of the actual plane itself as they're trying to communicate with the air traffic controller, or just their overall radar is going to be thrown off sometimes. But FCC, they highly regulate these devices, so that way they don't even make it to the market anyway. If there's something that is going to appear to be interfering with the communication system on some kind of aircraft, then it's not even going to make it to market. Once upon a time, if you took your cell phone into the ICU, they would tell you, do not get on your cell phone next to the IVs, because the IV pumps there used to be some interference that the cell phone would create. And I don't know of any cases specifically where it happened, but apparently back in the day, before technology got better, a single call on a cell phone could change the IV pump settings. And that, of course, we know could be problematic. But that's not even the case anymore. Even like on the planes, I'm not going to say that you should ignore their instructions, because on the plane they're telling you place your cell phones in airplane mode or turn them off completely, because even though they've kind of gotten over that. I mean, the systems are usually not that sensitive to like the signals that are coming from the cell phones anymore, but they still are going to just not take any chances, and they're going to tell everybody to make sure you turn your cell phones off or place them in airport mode, place them in the airplane mode, so that way it doesn't interfere with their equipment. Now, your transport program, it has to, of course, have certain things in place. Well, you got to have a safety officer, and you got to have some means of having some kind of like something happen, you got to do an incident report. So it's got to go through those channels, and then of course you got to have all of the policies in place, and et cetera. This annual safety training, I mean, it's just like things that just have to be done. You have to be checked off. And one of the big things is like survival training. You got to go out. They have to send you out to some remote place and see if you can survive. It's almost like, I guess the show Survival, where, you know, what do? You only got the clothes on your back and maybe a couple other things. And how do you make it? And how do you not end up freezing to death? And, or, you know, there's a fire, or, you know, how do you survive? And then et cetera, et cetera. So as you see, here's a sim rig where they can, of course, test you right on the spot and have you go through the process of like, what would you do, especially now you're come across some kind of emergency situation. Now, of course, to be checked off and to be competent and to continue to be on that team, you got to just know the basics of like these different lung problems that the babies have, you know, like what we've covered, like the RDS, BPD, and CDH, and et cetera, et cetera. And then as far as communications, I mean, all this stuff will be, of course, extra training that you would need once you do get on the team, and then you'll just have to continue to show competency. Stress management, this could, of course, be a very stressful position, especially if you do a lot and you've got some really sick cases, and that could be pretty stressful. And a lot of times there's a lot of burnout because they're on call a lot. And especially if it's not like an internal program, if it's like you're working for an outside type of company, you may be on call what may seem like around the clock, and you're getting called almost all the time. So it's good money. It's a lot of extra call pay and things like that. But over time, it can wear you out if you didn't have some means of disconnecting and just kind of like de-stressing from time to time. So they teach you that as well, how to try to de-stress so that you don't end up completely burned out. And I already mentioned like the survival training. They're gonna literally drop you off in the middle of nowhere and say, good luck, see if you can make it. But it's not that extreme, but it's structured. And then you got, of course, the boring stuff. You got to, of course, know all the regulations and laws and things like that. Now, this last slide, it's only here just to show you that this is still not all of them. This is pretty much like a rundown of all the different type of organizations that are going to be expecting you to follow their guidelines and their standards, and making sure that your team, they're up to speed on this and that, and they have their license, they're checked off, they're competent, and et cetera, et cetera. So as you see, it goes anywhere from COBRA to Medicare. I mean, everyone's going to have their say as far, especially when it comes to reimbursement. Medicare is famous for finding that one little tiny mistake that you made in your paperwork, so they can completely deny reimbursement. So I mean, you know, the FAA, they have their say in a lot of this because you're doing air transport, and et cetera, et cetera, et cetera. So again, this is nothing more just to kind of show you there's a lot of agencies that are involved, and you got to maintain your accreditation. Become deficient, and they'll give you a chance to fix your deficiencies. But as we know, if you are always coming up deficient, then you may end up losing that program. Okay, so the questions here, the ECMO pump itself. All right, so yeah, that's like the VA setup where they can change the pump speed, and that will definitely be the equivalent of increasing the cardiac output or decreasing the cardiac output. So in VV ECMO, it's going to be the right atrium. So the inferior vena cava, as we know, it is where it's inserted, but this is saying that where does the tip of the catheter end up? So where does it terminate? And it's sitting right there. If you go back to the picture with the catheter in place, the tip of it is sitting right there in the right atrium. So if a clot develops, which one of these would start alarming? Yeah, so it's that pre-membrane pressure, because if there's a discrepancy between, say, the pressure before the membrane, we're talking about the actual membrane itself that's doing the gas exchange, that's, you know, making the blood very thin layer and et cetera. So if the pressures before the blood goes into that device is much higher than the pressure on the other side of the device, then that's usually a clot. I mean, blood is backing up because of the clot on the before the membrane side. And so the alarm will let the specialist know. Why does ECMO work so well in a newborn? Right, so they're saying that a lot of the problems that the newborns have, they just need some support and given some time, then they could be okay. So reversible. Like think meconium aspiration syndrome. If they ended up having hypoxemic failure because of that, then give them some support and give them some time and continue to treat them, then they should be okay. True or false? Yeah, this is the problem with those unpressurized cabins. And if it's not pressurized, then you are definitely experiencing the exact same pressure that's on the outside of the craft. And that would mean less oxygen and hypoxemic or peripheral chemoreceptors will start to be activated. We should not consider transporting critically ill baby beyond, right? So that's our radius right there. I mean, really not going to try to go beyond 150. If you have to go beyond that, then we know you've got to consider the fixed wing method. How should you decide between volume control or pressure control? Yeah, it's going to really come down to the patient and what they need and how they're doing in that particular time. Okay, so that's all of the material that we have for this course,